Hello, my name is Tara Mallory, and I will be doing a brief education PowerPoint on ventilator assessment regarding asthmatics. We will basically just be going over some things that are commonly seen on the ventilator and when we assess it with our asthmatic patients. Forgive me, I am a little bit under the weather, so bear with me here. Objectives, common issues seen with asthmatics, common troubleshooting, vent graphics, and then a quick summary, just a breakdown of what we discussed. So just keep in mind these are the things that I want to touch on when going through this quick little PowerPoint here. Common issues seen with asthmatics. So we have air trapping, high peak pressuring from the air trapping, and mucus plugging, which can also cause high peak pressures. So basically air trapping happens because they have a longer exhalation time that is needed, and if they don't get that exhalation time, then they just start breath stacking. We all know our obstructive patients have issues getting air out, and high peak pressures are going to be the vent parameter that'll let us know if they're in bronchospasm, air trapping, or mucus plugging as well. There are other vent parameters that are specific when it comes to air trapping, but we'll get into those as well. All right, so this is comparing what I want to see with what I don't want to see. A is what I want to see, B is what I don't want to see. So A is going to be a volume control mode. That inspiration is great, expiration goes back to baseline, shows everything I want to see. Then the B, you have a breath starting before there is complete emptying. So if you see here, so I get back to baseline and then my breath starts here, okay? Here I have a breath starting before I'm completely done exhaling. We're not at this baseline, okay? Things that we can see is going to be a high peak pressure. You may have breath stacking issues, auto peeping. So the auto peeping is going to be measured with an exhalation hold on most ventilators, and we'll be able to measure the actual true amount of PEEP that the patient has within their body. That way we can titrate our vent accordingly to make sure we can either change the exhalation time, lower the PEEP, maybe the patient needs a different respiratory rate, maybe we need to adjust the flow or eye time depending on what mode the patient's on. So these are just things we need to look at. There's many ways of fixing the patient. I would say fixing because there's so much more to it. But there's so many ways we can try to adjust this incorrect waveform. So again, A, what I want to see. So we'll put a green little check mark over here. Check. That's what I want to see. And then B over here, X. Okay, don't want to see that. And if I do, I want to know how to fix it. All right, this is our flow volume loop. So this is showing inspiration, in, exhale, and it comes back to that baseline, or pretty close to it. So again, you want that. You want everything to go back to baseline. For however much I'm inhaling, I want to make sure I'm exhaling that amount. When I don't go back to baseline, it indicates that I'm air trapping. When I have a scooped out concave appearance, like you would see here, see, I don't go back to baseline. I want to be up here. Okay? It has a scooped out appearance showing that there was some struggling on that exhale and the patient wanted to go a little bit longer. So maybe it would have looked like this if the patient was able to truly exhale, but they're still not getting to that baseline at an appropriate time. So we need to adjust our ventilator to try to fix this. Okay? This is showing that the patient is having too much air, too much in, and not enough out. Okay? Simple as that. How do we fix it? Well, we basically just talked about it. We want to make some ventilator adjustments. So again, we want to adjust the IE ratio, change vent settings, suction possibly. Again, those mucus plugs are possible. Administer a bronchodilator. This will help with any high peak pressures that you may see as well if the patient has those peak pressures due to bronchospasm. And again, if they're intubated for asthma, which we do our best not to intubate asthmatics, then they're pretty much going to need some scheduled bronchodilators so we can help reverse the underlying issue. We know asthma is reversible because we treat the symptoms. So if I have an asthmatic who's intubated and bronchodilators are not going to be given, I'd be very confused. So that should definitely be something that's happening, even if there is no troubleshooting needed. It's something you should have for that patient and advocate for. Steroids with inflammation, and you want to wean quickly because, again, those asthmatic patients, we do our very best not to intubate them just because they're hard to wean due to that air trapping that can occur. So we want to try to wean them as quickly but as tolerated as the patient tolerates, because again, there may be another underlying issue going on with the patient that we're not sure about, or that we need to treat before we can even wean the patient. So, quick breakdown of asthma timeline when intubated. So, again, this isn't your every asthmatic patient that you have. This is just going to be those ones that are having those issues and that you may need to troubleshoot. So, you have asthma. Again, we have issues getting air out. We're able to get air in, but not air out. That's what makes it obstructive. So we have trouble exhaling, which causes us to air trap. I'm putting more air in than I am getting out. So we're just stacking air on air on air, which causes our ventilator asynchrony. So we may start peak pressuring. We're going to be auto-peeping. There will be a lot of factors that we want to look for, but the patient will be most likely breath stacking if they continuously are air trapping. This breath stacking and ventilator asynchrony can cause volume trauma to the patient. So we want to make sure that they don't end up getting a pneumothorax of some sort or having some underlying or other issues that may occur because we didn't change our ventilator settings. We want to make sure we're monitoring our asthmatics very closely when it comes to mechanical ventilation so that we can nip these problems in the bud as soon as possible. And again, you just want to see what's happening with the patient, identify it, reverse it. Okay, so breath stacking, adjust our IE ratio. Patient needs a longer exhale. Adjust your respiratory rate, adjust your flow. It just depends, again, on what setting you're on. So just be sure you know how to troubleshoot those things. Maybe even drop your PEEP down. Okay, maybe it's too much. Maybe do a combo of these things. The patient needs to be able to get that longer exhale that they need. With your patients with asthma exacerbation, they're going to have increased airway resistance for sure. The lung hyperinflation causes increased functional residual capacity and residual volume. So we know residual volume is the air that's left in your lungs no matter what. So we're going to have an increased residual volume if the patient's air trapping. They're not going to be able to blow off that residual volume, but they're going to have a larger residual volume from the air trapping. Dyspnea, decrease in respiratory rate, mechanical disadvantage of respiratory muscles, and a VQ mismatch. Increased air resistance and expiration only may mean an airway collapse. Airway obstruction rapidly reversed by therapy, such as bronchodilator. So these are just types of increased airway resistance that we may see. But you will definitely have an increase in airway resistance in your patient with air trapping and asthma. So mechanical ventilation in obstructive lung disease will have resistance to expired flow, results in air trapping, hyperinflation. Hyperinflation may result in cardiopulmonary compromise. The goal is to meet minimal requirements for gas exchange while minimizing hyperinflation while increased time for expiratory. So again, you want to have an increased exhalation time. We want to have minimal requirements for gas exchange with minimizing hyperinflation. We don't want to hyperinflate the patient because, again, they're prone to air trap due to that resistance to expire that flow due to that bronchoconstriction. These are my references, and thank you guys for your time. I hope you are able to learn something and able to apply it to your learning or refresh on what you already know. Thank you so much. Have a great night.